Feeling like a shark in a shrimp tank. Big fish, small pond in the shrimp tank.
Hey everyone, I'm Mark Scribner. I'm your host at the Shrimp Tank here in Boston with my co-host Mike Akil, who's based out of Sarasota today. And what we'd like to do is tell you a little bit about the Shrimp Tank. It's where book smarts and street smarts collide. We are featured in iHeart. You can download this show, Google Podcasts, Apple, basically anywhere that you find your podcasts. And we are now in something like 13 cities, now in Canada. There's about 1,200 shows that are featured, and you can download this one and all the past shows on those different platforms. Today, we're going to bring on Lisa Levine and Meghan Guidry from the Maven Project. Really exciting. It's an amazing story about telemed in the nonprofit 501c space. We're going to focus a little bit about how exactly a nonprofit runs and the similarities between a for-profit company that we'd like to kind of dig deep into. But before we do that, Mike, I want to just kind of get out there. What's your thoughts on the second stimulus package, COVID, and stuff that's going on in that space?
Yeah, it seems to be a lot of back and forth, but it does definitely seem like it's going to be directed more towards, helping individuals. I thought it was interesting, Mark. The hospital they're pushing Congress to forgive $100 billion in Medicare loans. It's funny, we've got here the Maven Project on, this telehealth nonprofit that's actually doing their best to help provide coverage and insight and direction for patients in community health centers across the country. But here the profitable hospitals are asking to have loans forgiven that have been given to them for the government programs in regards to Medicare. So clearly this pandemic it's wreaking havoc in the healthcare system. So I'm thrilled that we have the Maven Project on here with us today. And this is something that is really is benefiting many communities. And it's an area that is actually utilizing technology to help our communities. So it really fits perfect with what we're doing here at the Shrimp Tank, working with entrepreneurs, nonprofits that are embracing technology to make our communities better.
It's true. I mean, I have some friends that are executives at hospitals, and you would think that they were making money hand over fist, but the reality is most hospitals make money on elective procedures, the hip replacements, the shoulders, and things like that they're not able to really do in the typical telemedicine setting at the moment. So they lose money when you go in and you get hospitalized for COVID or things like that. And the other thing I just wanted to kind of hit on, Micah, too, is, well, obviously we don't know what the stimulus package is going to be. Both sides of the fence have different viewpoints. I think they all agree that something needs to be done. But on one hand, they're looking at some type of an incentive to go back to work. And on the other side of the fence, it is more focused on healthcare, first responders, and things like that. But more of the same for the most part. It's continuing the paycheck protection program, trying to extend that. So it'll be interesting to see how it comes, but I do think everyone's in agreement something needs to be done. The magnitude and the size of it is yet to be determined, but we'll be definitely watching that, reporting back. With that said, I would really like to bring on the Maven Project. We have two amazing professionals that were really at the forefront before COVID happened with telemedicine and the work that they're able to do across the country for the underserved, underprivileged people that have fallen through the cracks. And what they're able to do is amazing in my opinion. So ladies, welcome to the Shrimp Tank, and we're psyched to have you here today.
Thank you so much. We're thrilled to be here.
Yeah, excited for this combo.
I'm sorry, go ahead.
Oh, excited for the conversation.
We are as well. Could you maybe just take a kind of an infomercial, if you will, just to tell our listeners, what is the Maven Project in a nutshell?
Absolutely. The Maven Project is a telehealth nonprofit that supports primary care providers that serve vulnerable populations. So this is really the uninsured and the underinsured around the country that seek care in the safety net clinics around the country. And we help them deliver really exceptional, comprehensive care to patients nationwide via telemedicine. And we do this by recruiting a group of incredibly experienced volunteer physicians that represent 48 clinical specialties across medicine, surgery, behavioral health, for adult and pediatric specialties, from really top tier medical school alumni associations and other professional associations. And they partner with primary care providers and safety net clinics to educate, to advise, and really to enhance in-place care capacity, which is really in magnified demand given the COVID impact around this country.
Absolutely. It almost sounds like, Lisa, that's the demographic that's almost being impacted the most by COVID.
Disproportionately in many ways. Absolutely.
Yeah,
Absolutely.
I'd follow up that just here in Boston, for example, the unemployment rate is like 17%, but some of the lower income areas, they're 25 to 40%. And so I would think that your phone is ringing off the hook right now for services. And so I guess my question is, has that changed since COVID has happened? And like, how do you deal with that?
So, you know, I wish this pandemic wasn't here. And on the other hand, I'm grateful that our solution exists to be a partner, given the challenges at hand. Just kind of framing the world before the pandemic and the world as we see it now and moving forward. Before the pandemic, our country had almost 100 million folks that were underinsured. We have the highest chronic disease burden of any OECD country. We have a 25% higher death rate for the uninsured than the uninsured, with 18,000 excess deaths per year. And in this country alone, we have a 20-year life expectancy gap between the wealthy and the poor. So that's pre-COVID. Now with COVID hitting and what we're calling the second surge, we're seeing tens of millions. We have numbers of more than 40 million that are newly unemployed that we worry are gonna add to the uninsured and the underinsured pool. At the same time, we've asked patients and individuals and communities around the world to please wait, don't come in. We want to protect you. We want to protect our clinical staff. So we've delayed care. And in fact, many conditions are unfortunately worsening as we're doing that. So people are sicker. In addition, sort of social inequities are increasing risks around this country and magnified with COVID. And frontline providers that are delivering absolutely vital needed care are burning out faster. There's a rapidly intensifying shortage of providers. So the clinics that are really at the hub of delivering care needed for a growing sick population are understaffed and under-resourced as the community's need skyrockets. And for us, that crisis is one that needs, you know, solutions mapped with it right now. And that's where we come into play, which is we can help really expand local capacity and really empower and provide vital resources to frontline providers and to their communities virtually. And we've been doing, like you said, telehealth for, this isn't our first time, you know, addressing telehealth. We've been doing this since we started this model. So we know how to use telehealth, but I would say the silver lining in all of this is that telehealth has become foundational to how we're delivering care around this country. So more and more the light bulb has gone off around how to integrate telehealth into clinical practice and how we might be part of the solution.
It's here to stay for sure, I think, in my opinion. But
we agree.
Yeah.
Megan, who are some of the organizations that you guys have partnered with thus far to bring this to the communities?
Yeah, absolutely. So we have a wonderful partnership. Well, we have many wonderful partnerships with clinic partners across the country. I think we're in 10 states. We have over 100 clinic partners, and collectively those clinics help support well over 750,000 people just in their local communities. So, you know, certainly our clinic partners are instrumental, you know, in terms of, Lisa always likes to say, like, this is like, our business is really like anchored in relationships. And we're just grateful to have many incredible like relationships with different folks all working together to help address the challenges of getting care where it's needed. So, you know, another sort of key group is our physician volunteers are just incredible. We have, you know, they represent 48 different clinical specialties, and that can range from, you know, anything from, you know, family medicine to psychiatry to pediatric specialties, surgical specialties. So really almost any clinical question you could have, our volunteers can answer and can support. And then we also have a fantastic partnership with the the organization that makes the telehealth platform that we use, which is called VSEE, VSEE. And they've just been a long-standing and really transformative partner for us.
Do you, I mean, are you viewed as competition for the profit organizations out there? Like, I mean, I would think that you have a niche that obviously is not being served, is underserved dramatically, but what's the take on the for-profits? And we won't use the names of the bigger ones, but I'm sure we all know who they are. Do they view you as an asset or are taking away any market share from them?
So that's a great question. A couple of responses I would have to that. Number one, the communities that we serve may or may not be served by some of those organizations. So there may be some overlap, but there are a lot of spaces where the communities we're serving are under-resourced and don't have access to resources like that. The second piece is when we come into a community and we say we're able to really create this virtual multi-specialty group practice around every provider and provide resources that can help improve the health of communities and help frontline providers. There isn't anyone doing what we're doing and how we're doing it through medical consultation, one-on-one mentoring, and education. So we combine all of those as a service offering. But also if we come into a community and we ask them about resources available and they say, well, we've had this happen, you know, how are our local cardiologists going to feel about you coming in? That's a place where we'd say, well, that might not be a good fit for us. We come into communities where access is limited and right now magnified certainly by COVID, but where delays in referrals can be months to years. And so when we hear, you know, there might be competition, for us that may be a flag that there are needs that are already met, and our job is to come in where there are unmet needs and make sure we can help fill those gaps. So certainly the market, we're well aware of all the different players. We stay in touch with them. We're colleagues with a lot of them, and keep in touch with how we're all helping to solve the needs around this country. Certainly the industry of telehealth has exploded overnight, and you know, we're grateful for a lot of the policy changes that have come into play that have just made it easier to connect, because that's, you know, kind of blocking and tackling time zero. Just connecting is the first step in trying to really connect with patients and improve.
What I heard, it's like FEMA isn't gonna do hurricane assistance in an area that doesn't have a hurricane. You're going to the hurricane and just avoiding the areas that aren't in need or trying to.
Exactly. And for some organizations that are driven by profitable revenue, that might not be a place where they would see enormous, you know, gains. Now for us, we're funded really significantly by philanthropy and grants and some contributions by organizations that are able. But the return on investment for us are the health improvements, the avoided, you know, emergency room visits, hospitalizations, deaths. We're able to manage care earlier and sooner, and 70% of the time with our consult services, we're able to avoid a referral for a patient who would have been sent out of the clinic otherwise. And for these patients, we know that we work with some communities where the delay to see a urologist is a year or more. So if we're able to manage their care now, answer the needs now, we're able to avoid the conditions getting worse and that whole, you know, kind of domino effect, let alone the stress and burden it has on individuals, families, and communities and population health.
Yeah. Now, how are you organizing and keeping, you know, the volunteers, you know, updated and, you know, just the CE, the continuing education, how do they work in this particular environment? What's the Maven project doing for that? Because I know you guys work with education too.
Yeah. So two parts to that answer. So for our educational sessions, we offer continuing medical education credits. We actually offer a full year's worth of credits throughout the course of the year for our educational sessions. So some of our volunteers actually get some of their credits through our educational session. That being said, when we recruit volunteers and engage them and make them part of our community, there's a rigorous kind of credentialing process that we use to bring them on. They're carefully vetted. We even do a technology kind of assessment to make sure they're comfortable. The technology we use is simplistic and straightforward, but we want to make sure that everyone's comfortable using it, because that's the mechanism for communicating between our clinic partners and our volunteers. But we, and then we create mechanisms for really effective communication. We have newsletters, we have in-person gatherings, and committees, and virtual gatherings, I guess now, given COVID, but and committees that really keep them engaged with what we're doing and aware of both what the industry looks like and what the Maven project is doing. And for them, it's a relationship with us, and for us, it's a relationship with them.
Yeah, I have two questions. One's a little bit longer, but the first one is, how many people do you serve in a typical year?
That's a good question. So we can define it a bunch of different ways. So people served is how many clinics are we partnered with, how many primary care providers are we partnered with, how many patients do they care for, and those numbers are all different. That being said, what we can tell you, and Megan, you might want to add in here, but we had an amazing pro bono consulting relationship with the McKinsey & Company, and they helped us quantify some of the impact of our really amazing services. So one of the impacts that they helped us quantify is what we call the multiplier effect. And this is really that our volunteers both help answer questions that frontline primary care providers have, but while they're doing it, they provide clinical pearls. It's almost like each interaction is an intervention of sorts, informally so. And so what they found is that each consult provides education that answers a question at hand, but really enables information to be applied to really up to, and this is conservatively 19 additional patients that might look like that patient in a given year. So there's really a multiplier effect of our services that are really efficiently delivered, but create kind of an echoed effect. Megan, what would you add to that?
No, I mean, I think, yeah, that's perfect. And I know, Lisa, last year, I believe it was last year, you had a great, you did a great presentation with one of our provider partners, and there was a wonderful example you discussed with him around diabetes care management, where he shared, oh yes, this one kind of piece of advice or recommendation I got through consulting with one of the Maven Project's endocrinologists, that actually applies to 20% of my patients. So sort of in that one, let's assume 10, 15 minute encounter, that's care that can now be applied to 1/5 of this provider's patients.
So Mike and I like that word, the multiplier effect. That's what we do. We definitely like that word. What I wanted to know is, so we're able to interview some of the most amazing companies, and Maven is an awesome institution. But most people don't realize that nonprofits, they have balance sheets, they have overhead, they have expenses, they have capital requirements, and it seems like you have a lot of pro bono and volunteer work, which is amazing. But what's the thinking on how, like, you raise these funds, whether they be philanthropic or charity or however it's happening? But it is running exactly like a regular for-profit business. Is that right? Well,
So I'll speak to the front end, and then Megan, you can address the kind of funding piece. So our model is cost effective and efficient. Meaning we use in many ways, we use doctors as our partner, and they're part of our team, but they're volunteer. And they're part of this supply of providers that's leaving the workforce. So in many ways, we're repurposing them in a way that's actually a win-win for everyone. It's beneficial to them. They find tremendous joy in doing this, but it's tremendously beneficial to the providers that they're connecting with and to the patients that they're caring for. That being said, so some of our input costs might be lower than other organizations, but there are infrastructure costs of delivering a high quality service. Anything from credentialing our volunteers and covering them for malpractice insurance is just one example of operational costs that's rolled into a model like ours. So we have costs, and for us, one of the rate limiting factors to growing and scaling is ensuring we have the funding to support that. And for us, like, we're on this mission that, you know, our job isn't done until every community has access to our resources. And we believe more and more communities need us now more than ever. But Megan can talk a little bit to the kind of the fundraising side. We have operational costs like many other organizations that often I think gets lost when you hear of an organization driven by volunteers, but the infrastructure and the model still requires a lot of work.
Yeah, I'd love to know about the, you know, whether it be a startup venture capital firm, I mean, capital raise, having enough cash flow. Those are all things that almost any entity that's out there has to grapple with. I mean, in the service industry, undercapitalized, not able to sustain COVID for the most part, unfortunately. But you have to shake the trees all the time, right? I would assume to you know, get donations and things like that to keep the mission going.
Absolutely. I think I really appreciate you drawing those parallels between just, you know, any business entity and a nonprofit, because I think, you know, the Venn diagram circles overlap pretty considerably, just in terms of, you know, we need resources to continue to do the good work we're doing. We need additional resources so we can collectively help enhance our impact and enhance our reach. And I think, you know, one of the things I personally enjoy about doing kind of philanthropy work and fundraising in the nonprofit space is it really gives you an opportunity to work closely with partners, whether they are, you know, they work for foundations or they're individual donors, to really say, like, what impact do you want us to achieve together, and have that be the North Star that guides, you know, developing the relationship, continuing to express gratitude and share updates for their support. But it really feels to me like, you know, both a transparent and co-learning opportunity where we can work very closely with our generous donor partners to say, hey, you know, here's what we thought we, you know, here's what we started doing. Here's where we saw, oh, that's really interesting. Let's kind of either pursue that or let's pivot. And then here's the impact that we've had together.
That's
Yeah,
so go ahead.
Sorry. What I was going to add to that is, you know, the return on investment for someone is the impact we're making. So if somebody or an organization is interested in impacting, you know, health of communities and stability of the provider workforce, this is a way to achieve it that's efficient and really effective. And I think more and more communities and individuals are becoming aware of, you know, the mechanism of telehealth, just given the necessity with COVID. But the impact we're making, and we have quantified, you know, cost savings for an individual, and, you know, just with a consult alone, of avoiding that escalation of the condition, the emergency room visit, the hospitalization, the unnecessary test, keeping the care local. But it's also, you know, enabling that individual to go back to work and to, you know, maintain a job and an income in ways that really stabilize communities, but also improve population health, but also, you know, have a return on investment for really every party in the system.
I have a weird idea. What if every health insurance company was required to give 10% of their profit to the Maven project, and they could expand all the underserved areas instead of minting dollars?
That kind of goes along with my. So what if a donor wants to bring the Maven project to a community that's close to their heart? What comes first, the clinic or the volunteers? What's the steps to get something like that in place?
So it's sort of a match, and we can come from either angle. So we have a we have a kind of a wait list of organizations waiting to access our services, whether it's based on not having funding paired with it or just based on, well, mostly it's that because it's a capacity constraint for us. But we have funders that come and say, we want to, you know, support something in my neighborhood, and we may have an organization already on our queue that we can pair up with the funder. On the other hand, we can come kind of vice versa, which is clinics come to us, say we're looking for your service, and then we can pair funding as well. So it can go either way. And you know, it's our job to make those matches and execute on that. We want our services in every place that needs it.
What's the biggest limiter for you to expand this outreach of the Maven project? Is it just capacity or money? What's the biggest thing that you have as an obstacle right now?
Yeah, I think it's capacity as it relates to funding. The other piece is, and it's just resource intensive, but ensuring that we're really identifying and matching what we'll call good partners. And when I say good partners, I'm saying in quotes, but a partner that's going to be a partner that uses our service, that accesses our services, that's committed to it, but also that's ready to take on any new initiative. There are some organizations that are in need but don't have the capacity for anything new right now. That would not be a good fit. It's not a big lift to put our services in, but like anything in healthcare, any change takes some leadership, ownership, and, you know, dissemination across, you know, all the operations and across all the staff. So we want to make sure that we're pairing ourselves with clinics that are ready, and ready could be significant need, and, you know, and I'm ready to use it. But we want to make sure that they're good fits for us as well.
And do you
Megan, anything you'd add to that?
I would say too, you know, one of the challenges that we're starting to see is also just that the need is growing so exponentially, but as the, you know, with the kind of 1-2 punch of the pandemic and the economic aftershocks, we're also seeing sort of whole regions, you know, that were, you know, maybe just a few months ago, you know, had better access, had greater economic stability, that are now kind of getting into more precarious positions. So I think a big part of our work as well is to really kind of make sure we're being proactive and looking at, like, what are these trends? Not just how is the entire country being impacted, but like what might the unique needs of different regions be? Like, you know, going back to the FEMA analogy earlier, like we know some communities, some geographies that, you know, where like hurricanes and natural disasters come on certain cycles, there might be just a disproportionate need there depending on how the hurricane season progresses.
And the other piece, as an aside, is that, you know, we're constantly in touch with our clinic partners to also just learn what are their day-to-day needs. And so we've been able to help really connect many of our clinic partners with even just basic PPE. For example, one clinic said to us, we're using garbage bags as, you know, gowns. Can we get some help? And so we've been able to make those connections through, you know, relationships and partnerships that we have, just to help in other ways too, that we know, you know, just helps meet the need.
Do you get a collaboration from like governors, mayors, like Washington? Are they part of the fold that you interact with, or is it just all boots on the ground type of an approach?
We're having conversations in many of those places with certainly a goal. You know, we would love this managed at a national level in an organized way, certainly from a COVID response perspective. But I think certainly we're having conversations with local government and with national or federal organizations. And that would be a goal of ours to partner up there. I think some of the challenge with how healthcare is being delivered right now is it's really being managed, even as it relates to COVID, in a regional manner. And that's causing some of the challenges we're seeing with the spread and the testing and everything else, which is we're not coming up with, state, national standards for how we're looking and how we're managing and deploying resources, which is a missed opportunity.
Yeah, absolutely. I'd like to just take a quick pause. We're almost out of time, but I would like to remind our listeners you can download this show at theshrimptank.com/Boston, iHeartRadio, Google, Stitch, SoundCloud, Apple, basically anywhere that you can download your podcasts. Folks, we want to both thank you for your time today. What is the best way to get a hold of you for anyone who wanted to make a donation, check out the Maven Project and the great work that you are able to do?
Probably the easiest way is just our website, which is Maven Project, MAVEN project.org, O-R-G. And there are links right at the top to our COVID initiative, link to make a donation, links to get involved, and to our social media. So I think all of those, that would probably be the central hub way to connect with us. And we really look forward to hearing from all of you.
Thanks so much for your time today.
It's nice having you both on the show.
Thank you.
Thank you.
Thank you.
I've been feeling like a shark in a shrimp tank. Big fish, small pond.